Today's briefing is interpreted in Spanish, Mandarin, and Korean. We will send a recording of the session to all participants this afternoon. If you have questions for the speakers, as I hope many of us will, enter them in the chat, and we will take as many as time allows. We encourage our speakers to follow the questions on the chat and feel free to answer those you feel particularly relevant to your expertise. Now let's begin. Dr. Lucía Abascal, who has appeared on several EMS briefings to help us track vaccines during the pandemic, will lead off with an overview of Alzheimer's and what it will take to realize the governor's campaign mission of shifting public perceptions about the disease. Dr. Abascal.
Yeah, thank you, Sandy. Good morning to everybody. Thank you for joining us today to learning about this critical effort. So I think Sandy took many of my talking points today, but I do have some newer stats.
Repetition is really very welcome for us as journalists, and especially around data.
Yeah, I agree, but I do have like a special surprise in there. So,
okay.
I think me and everyone is still surprised to learn that Alzheimer's disease was, so this is the update, was the third leading cause in death in California. But the recently published 2024 report on public health in the state by CDPH actually ranks it as the second leading cause of death for older adults in California. So it is a pretty big deal. And the big part of another big part of this is that by 2024, by 2040, we expect the numbers to double. So as the population continues to age, we expect these numbers to grow as well. And also, a very other important thing is that the big disparities exist within Alzheimer's. So it's not only a big problem, but it's also a bigger problem within some communities. We know that women in communities of color are more likely to develop Alzheimer's. So it is a very big deal. And as we were saying, the primary risk factors for Alzheimer is age. And we know that California is a huge state. So we have the biggest concentration of older adults in any state in the United States. So these are just some stats to prep us of, so what are we doing? What is the purpose of this campaign? So the Take on Alzheimer campaign is the first ever statewide Alzheimer's disease campaign, and it was developed by CDPH to shift perception and reduce stigma around Alzheimer's disease. So we know this is a big problem. It's going to get bigger, and we want the communities and people to know how big it is, but also to shift perceptions. And as Sandy quoted, one of the other guest speakers we have today, make it a dinner table conversation. The issue with fear and stigma is that it prevents health-seeking behavior. So many people and their families might be afraid of getting diagnosed, or might be scared of the stigma that a diagnosis comes with, and might not seek healthcare, when we know that it is essential to have an early diagnosis, since that opens some legal doors and some healthcare options. So the idea is that the earliest the disease is diagnosed, the better it is for the person with Alzheimer's and their families or caregivers. This is a disease that progresses. So it usually, the nature of the disease is that it gets worse with time. And that's why getting a diagnosis in the earliest stages is our goal. There is a lot of great work already happening within our communities to combat the impact of the disease. And this is why the campaign also includes coordinated efforts to build and strengthen our partnerships with community leaders and organizations across the state of California. We are eager to learn ways we can support local and innovative efforts to combat the impacts and stigma of Alzheimer's disease within all communities in California. And I know I personally have 2 family members that suffered from Alzheimer's disease, and I'm sure that many of you also have somebody close to you that has been diagnosed. So it is important to recognize that we all have a role in taking on Alzheimer's. With your help, we can educate and empower Californians to recognize the signs of Alzheimer's disease for themselves and others, start a conversation with friends, loved ones, and other healthcare providers, and then learn ways to reduce risk and improve brain health before or after an Alzheimer's diagnosis. Together, we can take on Alzheimer's.
Could I ask you a quick question?
Yeah.
How can you address brain damage once the disease has begun? What are some ways we in our own families or communities or as journalists can think about encouraging people to consider? Some people say taking turmeric. Some people say eating blueberries. There are many fears around Alzheimer's, but there are also many folk remedies, which is what I considered blueberries and turmeric, not to be devalued, but to be understood.
Yes, and I think that's a big part of the campaign, as I was saying, is to listen to communities. Different communities might have different approaches. The main idea of this campaign is just to create, not just to, but to create awareness on the disease, right? And try to understand different perceptions from different communities. We want people to know that, first of all, there are things that we can do to take care of our brain health, even without the diagnosis, but also after that diagnosis. We also want, there's a misconception, we want to shift perceptions. So I think one big misconception about getting older is that as you get older, everybody will kind of lose their memory or lose some functions. So instead of attributing that to Alzheimer's or a disease, there's communities or people that just think that it's, oh, they're getting older and don't seek care. We want to shift perceptions on that. Yes, it's normal to forget some things. I sometimes, many times, forget things, but Alzheimer's is different. So we have a progressive memory loss and other symptoms, and we want to make those signs and symptoms make people aware of them so that they can recognize those symptoms in themselves and others and seek medical care. That's the second biggest part of the campaign. There are options for people that have Alzheimer's. There's screening tools, diagnostic tools, there's treatments. There's a lot of research in this area. We expect care and therapies to even get better. So that's why it's so important to take this first step of raising awareness and shifting perceptions and stigma of the disease.
Thank you so much. There are questions for you in the chat, and then I hope you can stay on because we will have a final round of Q&A with our media after the presentations. We go next to Dr. Dolores Gallagher Thompson, who has a long history of working on Alzheimer's with Asian American communities, and will speak particularly about stigma in the Chinese community, also maybe on the Vietnamese. Dr. Gallagher Thompson, please go ahead. Okay, you need to unmute. Okay, let's see if Jessica, can you help Dr. Gallagher Thompson?
Got it.
Great, thank you.
Thank you. Took a few tries. Sorry, folks.
Oh, you're terrific.
Okay, so I'm so pleased to be here. I'm really very honored to be part of this discussion and would like to share with you some of my experiences. 30 plus years working with diverse communities, marginalized communities. In particular, for this discussion, I'll focus on Chinese and Vietnamese caregivers. So they are a large group because of the large numbers in the population, and both groups have not been studied very well in the US. There are a number of studies of Chinese caregivers in China, but not here in the US. But what the studies that have been done, what they've shown is that there is oftentimes a sense of great stress involved in caregiving, because for many of the younger generation, which are the caregivers, typically the middle-aged, 40 to 60 range daughters or daughters-in-law are the typical caregivers in the Chinese community, the primary caregiver. And they are often in the sandwich generation of caring for the adult parent or parents-in-law, as well as their own children, who may at that point be teenagers. There may even be grandchildren in the picture, depending upon the family constellation. So there's a great deal of stress juggling all of this and trying to manage the responsibilities of caring for the older respected family member, as well as the younger family members that need attention too. So this creates a good deal of perceived stress. Oftentimes depression is reported as the next most common feeling that many Chinese caregivers say. And partly it comes from this concept, I think, of filial piety, which has been traditional in Chinese culture for many thousands of years, I believe. But in this, at this time in this country, it may not be as heavily endorsed by the younger caregivers. So the older generation, the care recipients, expect the filial piety to be carried out. The younger or middle-aged caregivers are not necessarily fully endorsing it, because it means this conflict in the family between all of the roles, the multiple roles that they have to fulfill. So it's challenging, therefore, to develop intervention programs. You know, Lucía Abascal talked about the importance of treatment for individuals, and I certainly believe that. I also believe, though, that you need to treat the family as a unit, you know, not just the individual person with dementia, that's hard enough, but to think of the family, that they are really our patients, because dementia affects everyone. So from the spouse, the younger generation, the children, the grandchildren, how do you talk to children about dementia is another complex topic. But just in the interest of time, I'll say that I have found that education is very important, as we've been mentioning, the importance of helping the family understand that dementia is a neurological condition, not a psychiatric condition. So it's important, I think, in the Chinese community to remember that traditional Chinese writing, the character is exactly the same for crazy and for dementia. They are the same character. And since most traditional Chinese has been used for centuries, modified Chinese is now used in this country more commonly, but still for the older generation, that's the concept that they have, that they are going crazy, and the family often thinks the same. And once they make that attribution, then the shame and the fear and the stigma escalate. Understanding that dementia is neurological helps with that. So that's a key component, I believe, of any successful intervention. I think a second key component that our research and research of others has shown is the importance of helping the caregiver learn different perspectives. So how can they manage better? How can they reduce their own stress? So in our programs, we teach caregivers a variety of skills. So when there's problem behavior, what do? You don't ignore it. You need to respond to it. And how can you respond in ways that are less stressful for everyone involved? We have a section on communication. How do you communicate effectively with your loved one with dementia? Not the same as the way it used to be, because they don't understand or they can't respond. So you need to learn other ways to communicate, like with touch and feel and non-verbal methods of communication. And I guess the last thing I will say is the importance of caregiver self-care, which is a difficult construct, I believe, in many Asian communities. And I found in the Chinese community and in the Vietnamese community, we can't call it that. We don't call it that. We say learning ways to be a better caregiver. It involves taking care of yourself, and putting it that way seems to make it more acceptable. And of course, these interventions I'm talking about were developed with the input of the various the specific communities. So with community advisory boards and a strong effort to cultural inclusion and cultural relevance of the materials. And I'd be happy to share any of these that we've developed or to answer other questions as we go along.
Dr. Gallagher Thompson, you said when we talked earlier that there's also a need to give people with Alzheimer's a sense of the importance of their role ongoing. And could you say a little about that? That would be helpful.
Yes, and yes, I think that, for example, focusing again on the Chinese culture, for many women who are now experiencing Alzheimer's or some form of dementia, cooking was an important part of their lives. Being able to prepare the family dinner, cook good, delicious and attractive meals and so forth. Well, part of what happens with dementia for many individuals is that they can't do that anymore. They might put the rice on the stove and it burns. It's not really edible, or they put the wrong ingredients together, and so the dinner is not successful. However, rather than become frustrated and irritated and kind of say, what am I going to do now? The more helpful approach is to figure out what can the person still do? How can they contribute to the family dinner? They are there, they want to contribute. It gives them a sense of meaning and value if you can find ways that are safe and appropriate. So for example, maybe the person could make the rice with some supervision, with somebody helping, watching and helping, or they could set the table, or they could prepare some other part of the meal that isn't as complex or doesn't involve the stove. So you think of ways, and it's remarkable the difference it makes when the older individual with dementia feels included in the family versus not included.
Thank you. There are many questions in the chat, and thank you so much to our speakers who are responding to these very important questions. This question, I think many of us share, is Alzheimer's something that can be prevented before it happens? Is it genetic or is it environmental? These are very basic questions. Maybe either Dr. Gallagher Thompson or Dr. Abascal would want to address them, but there are several questions that go to that issue. Is Alzheimer's something that can be prevented before it happens, or is the research just not there to tell conclusively?
I can take that question if nobody else has a better answer. So we know that there's things that we can do to reduce the risk of Alzheimer's. I think just staying physically and mentally healthy, I know that's a broad term, is important. And what do I mean with that? There's a big exercise. Exercise helps a lot before we get Alzheimer's, but also when we get Alzheimer's, it's also it's great. It helps with blood flow through the brain. It keeps us healthy. Eating healthy also is important. We know that there's a big correlation also with having chronic diseases that affect blood flow to the brain. For example, diseases such as hypertension, diabetes, disease risk factors. So having those controlled is also very important to help reduce our risk of Alzheimer's.
Great, thank you. And Dr. Gallagher Thompson, you have had some experience in the Vietnamese community. What would you say is unique or in your experience about the cultural lens towards Alzheimer's among Vietnamese?
Yes, it is a unique experience for many because of the experiences of the war in Vietnam. And so many of the older people who are demented now also experience PTSD, as well as the caregivers, because the caregivers are the ones who oftentimes brought them here. And it's difficult. It adds an extra layer of complexity to the intervention program, because we need to be aware of the impact that PTSD has on people, which is depression, a whole complex of symptoms that can make caregiving even more challenging than it already is. So in the programs that we've developed for the Vietnamese community, we have a segment on that, on encouraging people to share some of their experiences, how they've coped with those experiences, and how they think that might impact on their caregiving. And it's a very rich culture, as is the Chinese culture, as are all other Asian cultures, but these are the two that I've had personal experience working with, and I've been struck with the resilience in these communities, that despite the many oppressions that they have faced in multiple ways, and particularly with an immigrant status, they have nevertheless built up their own inner strengths so that they're able to take on the challenges of caregiving in addition to everything else. But they need support, and they need programs that are tailored to their specific cultural values and beliefs. And I think we have a lot more work to do in that arena.
Thank you so much for joining us. And we know you're dropping off for the religious holiday, and we so appreciate you joining us today. So we'll move now to our next speaker, Dr. María Aranda. And Dr. Aranda, you have a long history with Alzheimer's. You're on the governor's task force, and we're especially anxious to hear your observations about stigma as it impacts especially people in the Latina communities. Thank you.
Thank you, Sandy. Thank you for the nice introduction, and good morning or good afternoon to everyone online, depending on where you are in the country or the world. I'm very honored to be here, and I'm very happy to see many of my colleagues in the live stream today, including the panelists. I've had a long history working in the space of dementia, and a long history working with families that are challenged with living with this disease. Even in my own family, we've had individuals that have been diagnosed with dementia of different types through the years. So this is something of both a professional and a personal interest of mine. So again, I'm very honored to be here today. Stigma is alive and well. It's alive and well in any society, in any cultural group, when we talk about memory loss. And although today we're talking about Alzheimer's, we do know that there are different types of dementias, including vascular dementia, Lewy body, frontotemporal dementia, and many other dementias that we cannot take the time today to talk about. But we know that whenever we talk about memory loss in any group, in any family, it's typically a topic that does not make dinner time conversation. It is something that's typically shunned, something that is typically put away, not talked about in our society. And I see this also in the Latino community as well. When I say Latino, I do want to acknowledge that this is not a monolithic group, that this is a very diverse group represented by different places of birth, nationalities, language capabilities, et cetera, et cetera. So I want to acknowledge that, but I'd like to make some general statements. You know, there's a societal and there's also individual stigma, and societal stigma is typically what our society says is normal or normative. And we know that there is a high price and a lot of hierarchy put on people's intellect and intelligence and competency and ability to compete in this society. So when a person begins to show memory loss, cognitive decline, memory impairment, there is typically, what follows that typically is a reaction of shame, a reaction of fear, a reaction of maybe this is not something we need to talk about publicly or even within our own family. And unfortunately, what happens is that there is also personal fear, where, for example, I work a lot with family caregivers, caring and providing assistance to people living with dementia and memory loss, et cetera. And I hear a lot about, you know, why should I be telling people about this? They're going to treat us differently. They're going to treat my loved one differently. They won't get the care that they need or the services that they're eligible for. So there's this kind of two forces, societal stigma on one side and personal family stigma on the other. And what happens then is in the Latino culture, if there's already a family member or family members with memory loss, there's this wish to be protective of the individual and protect them against more stigma and more discrimination and more marginalization. So this stigma then prompts what I call a cocoon experience, where they protect the individual so much that they may be missing out on other things. Number one, getting services altogether, for example, adequate diagnosis of dementia, being able to marshal family resources and people in their family and close friends and close neighbors that can perhaps help them in some way. And then third, there's also the overprotection could preclude individuals from being able to, for example, participate in clinical trials. So we see that in a lot of the work that we're conducting in the Southern California area. And for example, I have a caregiving study right now that is funded by the California Department of Public Health, Alzheimer's programs. And because of the funding that we received from this department, we've actually been able to provide caregiving services to Latino families and other families as well. It's not just on Latino families, to be able to increase their knowledge about dementia, healthy aging, brain health, caregiving, et cetera. And it's in conjunction with Alzheimer's Los Angeles. It's good to see Petra also on our call here, and Alzheimer's Los Angeles and the University of Southern California Roybal Institute on Aging are actually working towards providing people accurate, timely information on memory loss, cognitive aging, brain health, caregiving, et cetera, et cetera. So when I think about stigma, I also think about what would be other reasons why people from the Latino community would miss the mark in terms of understanding what this is all about. And aside from the stigma, there's also the belief that memory loss is a normal part of aging. And that was already said earlier today, so I don't want to go too much into that. But we do know, though, that the most prominent risk factor for Alzheimer's disease is aging, is older age. So in some way that is true, but it doesn't mean that everyone that reaches a certain age is going to have a neurocognitive disorder like Alzheimer's disease. The other aspect that I see in the Latino community is that loss of memory, a la Alzheimer's, is equated with mental illness, such as psychotic disorders. And what I see here is almost like a spectrum, but it's very polarized, a very polarized spectrum. On one side, think of it as normal aging, as I just said. On the other side, you see it as part of a severe psychiatric disorder, such as schizophrenia, other types of psychotic disorders. And so there's this gray area in between where people then, because they have a lack of health literacy regarding this area, regarding all of these terms, then everything else begins to fill in the blanks. So you have a lot of misinformation points in that gray area where people then hear this, hear that, put things together, and then have a lot of misperceptions about what this is. And part of it is cultural, part of it is lack of health literacy, but also we have another force here that is at work. And that's the issue that healthcare providers, professionals, lay professionals from Health and Human Services also have stigmatized ideas and biases that fill in some of those gray areas that I just talked about. So we have to understand it is a two-force process that is occurring here. It's not just the individual that happens to be Latino or Latina or Latinx. So we have to consider both sides of the spectrum.
I have to ask you to wrap up in just more minute. It's each of you is so fascinating, but just in the interest of time.
Absolutely, no problem. And the last thing I want to say is the language issue. People who are monolingual Spanish speakers have less access to timely, accurate information in this space, and as a result, are not able to obtain the important and key information they need to help their older adults to prevent memory decline in the future, and also to buttress caregiving needs and preferences. With that, I'll stop there. And Sandy, it's all yours.
That there are just wonderful questions and wonderful answers. I urge everyone to keep an eye on the chat. And Dr. Aranda, if you don't mind answering a couple of questions that came in specifically to your remarks as well. We will go now to our next speaker and welcome Luna Crisanta, who will discuss stigma's impact in the LGBTQ plus community. Thank you, Ms. Crisanta.
Thank you, Sandy. Thank you all for joining us today. I'm Luna Crisanta. I use he and they pronouns. My team and I work closely with the Alzheimer's Association and Family Caregiver Alliance to provide free trainings that speak to the specific needs of LGBTQ individuals dealing with Alzheimer's and dementia. We also offer more courses on cultural humility and best caregiving practice for the aging community. So the Two-Spirit LGBTQ community is unique because it's made up of people from all walks of life. There's LGBTQ people of every race, ethnicity, nationality, ability, and religion. Researchers estimate that there are about 2.7 million LGBT people who are over the age of 50, and that number is growing rapidly. We actually think there's even more adults who would fall into that category than what's currently being reported, but I'll talk a little bit more about that later. Our elders have lived through times of great change. I'd like us together to imagine an elder who is part of what we know is called the silence generation of LGBT older adults. Currently, they'd be around 70 to 90 years old and were born in the 1930s and 1940s. In their lifetime alone, they were growing up during the lavender scare of the 50s, where LGBT individuals were being outed and fired from their government jobs because of a fear that they could be manipulated or blackmailed by communists. They also lived through a time where homosexuality was considered a mental health disorder, and people were subjected to horrible treatments like electroshock therapy and conversion therapy. Things started to change in 1973 when homosexuality was removed from the DSM's list of mental illnesses, although I want to note that gender identity disorder stayed on until 2013. Our elders' identities were shaped by civil rights movements like the March on Washington for Jobs and Freedom in 1963, desegregation efforts beginning in 1954 and continuing to the mid-70s, as well as the first LGBT-specific uprising at Compton Cafeteria here in San Francisco in the Tenderloin District in 1966, where trans women and sex workers pushed back against continued police harassment and brutality. Unfortunately, this elder would also share a collective trauma of losing over 100,000 community members during the HIV and AIDS pandemic of the 80s and 90s. That very same elder who was criminalized and pathologized for a majority of their life, and who has finally come to terms with themselves after years of struggle, is now aging into home health or long-term care. This can feel like they're losing the agency and the independence that they fought so hard for. Out of the 2.7 million LGBT people over the age of 50, 7.4% of lesbian, gay, bisexual older adults have dementia. This number comes to us from the Alzheimer's Association and SAGE. Despite all the barriers and consequences, our elders are resilient, and we want to honor that as they need more support, and especially if they're experiencing dementia or living with a diagnosis of Alzheimer's or dementia. Personally, that's what drew me to this work. I'm Kanaka Maoli, that's Native Hawaiian, and Mahu, a third gender and queer person. Though I'm still working to deepen my cultural connection in my adulthood, I grew up understanding how sacred relationships with elders are. Talking story and sharing wisdom from their experiences is something that I take with me and that guides me in my own life. And at Open House, and for me personally, we hope to see our elders live and die with dignity and surrounded by their community. Unfortunately, they found that when many of our community members start to age and need more of that care assistance, they end up feeling like they need to hide their true selves again by going back into the closet. A 2023 study from the Williams Institute of UCLA shows that this happens because of prejudice and discrimination they face throughout their lives. Estimates show that 40% of cisgender, LGBT, and 46% of transgender older adults don't disclose their sexual orientation and gender identity to doctors because they're afraid it'll affect the quality of care that they receive. Transgender and gender expansive individuals face more challenges in living their authentic gender identity as they age. This fear of discrimination stops LGBT older adults from seeking preventative care that they need. And we know, as many of my fellow speakers have addressed, how important that early diagnosis is for dementia and other diseases. According to a 2010 study by the Movement Advancement Project, SAGE, and the Center for American Progress, 8.3% of LGBT older adults have reported neglect or abuse from their caregivers because of their sexual orientation or gender identity. And this abuse can be physical, emotional, psychological, and is deeply damaging to our elders. Again, from that 2013 study, that also shows us that LGBT older adults experience more economic insecurity, they have lower incomes, are more likely to struggle with food insecurity, and rely on alternative forms of income and assistance. For example, 21% of LGBT people aged 50 to 64 and 19% of LGBT people aged 65 and older had household incomes below the federal poverty level, compared to 15% of straight and cisgendered adults. This report also shows that there's significant economic disparity within the LGBT population based on race and ethnicity. All of this makes it harder for our elders to safely access quality care, especially when they're dealing with Alzheimer's and dementia. Lastly, I want to mention that our family structures in the LGBT community often look different than the cisgender and heterosexual family units. Two-spirit LGBTQ elders have often faced rejection from their biological families and found support in chosen families that love and accept them. It's truly a beautiful thing, but those chosen families often consist of people around the same age and lack that intergenerational component that biological families have. Traditionally, as people age, they have children who grow up and care for them, advocate for them, and eventually have children of their own to continue that cycle. But for many of our elders, they are aging at the same time as their loved ones and find themselves being caregivers while also needing that support themselves. At Open House, we work to bridge those gaps in support, and we were created to build that community in San Francisco and address the challenges our elders are facing. We recently celebrated our 25th anniversary, and in that time, we developed 110 units of affordable housing and built really important intergenerational programs like our family visitors. We have a robust housing navigation resource center connecting thousands of elders to vital support. We have an in-house mental health program that offers short-term support to our community members. And we're very happy with our new Community Day program made in partnership with Unlock Club 75 that really addresses that higher level of care, social programming, and pathway to medical resources for our elders. There's still so much more to say about our community. But before I go, I want to leave you with a story. There's a longtime community member who used to struggle with isolation, lack of support, and connection before joining us at Open House. Through her participation in programs like her Trans Resilience Support Group, her founding membership in our Club 75 program, and by sharing her experience as a proud transgender woman and intersex person with us in the Training and Transformation Department, she now feels like she has fully come out of her shell. Recently, she even took a huge step in continuing to live her authentic gender identity by legally changing her name. I can recall the apprehension she had when filling out the forms and fear in dropping off those documents at the courthouse. This was unmatched by the joy she experienced when she got her approval, and I'm so excited to continue to help her plan her new name birthday party. I share all of this to say that these small steps of support can really help make it just a little bit easier for our elders to continue living their lives to the fullest. Thank you.
Thank you very much. That was very eye-opening on a community that perhaps we don't think in terms of elder and isolation, but you've so effectively focused our attention. Thank you. Finally, I want to turn to our speaker who will discuss the importance of stigma in the African American community, Petra Niles. Thank you, Petra, for joining us. We're very much looking forward to your remarks.
Good morning, good afternoon to everyone. Thank you so much for the invitation to speak. And as Maria Aranda said, the Black community is not a monolithic group coming from various countries and places. And so that should be considered in research as well as what is written about the community. Just a quick glance at Alzheimer's, a type of dementia, the most common type of dementia. The World Health Organization has shared that there are 55 million individuals who have a dementia. In the US, there's approximately 7 million Americans that may have the type of a dementia, which is Alzheimer's. Then in California, those who are age 65 and older, 719,000 people in California are living with Alzheimer's disease. As it relates to the Black community, Black Americans here and throughout the nation, they're twice as likely to have Alzheimer's or another dementia as compared to older whites. When we think about dementia, defined as when someone's thinking declines to the point of seriously affecting their day-to-day life from the time they get up in the morning until the time they go to bed, that's a number of people, specifically as it relates to began January 1st, 2024, the number of individuals who are turning 65, that's a real critical number to consider. In the Black community, there are many, many labels. There are many historical perspectives that affect this disease and many other parts of life for Black communities. And so there's a critical need for awareness about this disease. Blacks are also at highest prevalence for high blood pressure, diabetes or blood sugar issues, cholesterol, and other areas of their health and social determinants of health, which affect overall lifestyle and ultimately their health. So you will see how being twice as likely is one of those areas that has affected this community as well. When we speak about early diagnosis, it's important to define that. One of the challenges, it's not a challenge, but I realize when I'm speaking to the group that's highly affected from this disease, I have to make it very clear. So if I mention early diagnosis, what does that actually mean for a group who has been identified as being diagnosed 10 years plus into the disease? So I have to clearly define that it's the time frame when an individual receives the diagnosis. And when I'm talking about warning signs, whether there are issues with memory loss, issues with getting lost or wandering, issues with finances, repeating stories, and things like that, that I share, you don't have to wait for 5, 6, or even 4 of the symptoms or warning signs before you go and have a conversation with the doctor. But if there's one that's concerning, please make sure to go and have conversations with the physician about what you're noticing, when, how often, and things like that. It's important for this group to feel that they also have a good relationship with a physician whom they trust, who will respond to questions and concerns and not say, well, your mom is getting older and this is a part of aging. That helps with not giving accurate information. And as was mentioned before, communities believe that this is just a normal part of aging. So it is really, really critical that when we write about this disease in various cultures, that when we present information to various cultures, that it is very, very specific. In mentioning the word caregiver, that I have to often define what that is for those who assume that a caregiver, the role is something that they do. For many communities, it has to be defined because they prefer to just simply say, I'm the daughter, I'm not the caregiver. I'm the son, I'm not the caregiver. So defining caregiver is important as well. Family caregiver versus paid caregiver, and just having a conversation about that word and what it means when they are in a healthcare setting, that they may benefit from some of the information, the resources, and potential care, just simply asking how they're doing and potentially looking after them as well as the patient. So there's a lot that I have considered in my work, in working with the African American Black community. The stigmas in the community, as Maria said, are live and well. They're, again, defining caregiver, defining what stigma is, then the self-stigma, where people living or have been diagnosed with this disease, how they internalize negative feelings about themselves and the relationships that they're in. Then there's social stigma. What do people think? Laughing, maybe negative labeling. Then there's structural stigma. Government, companies, workplaces, restrictions on rights and opportunities based on the diagnosis, can no longer drive. There are many, many areas here to consider. So I just want to end with, this is a disease that's not going away. Diagnosed in 1906, the first person was a woman, August Dieter, in 1906. It continues today. There is no cure. There's a lot of work to be done. How you describe this disease matters because it's very scary. So from the perspective of health, of brain health, that may be an entrance to a better discussion about Alzheimer's. Thank you so much for your time.
Thank you, Petra Niles. Is there a particular characteristic of Alzheimer's or cognitive decline, dementia, that makes for a cultural stigma in the African American community? You've explained very well how fear of losing a job, of being discriminated against on the basis of suspicion of cognitive decline. But what about family members and neighbors looking at somebody who is showing symptoms of cognitive decline? Is there sympathy or is there fear? How would you describe the stigma?
Stigma does affect reaching out to get help, reaching out for services. It also affects not sharing that information that your aging parent or spouse is having areas of memory being challenged. And so not sharing with a neighbor, but is there at least one or two trusted neighbors? Because the risk for wandering or getting lost is very high. And so if someone gets out and the family members are at home, they're also at home, somebody walks down the street, the neighbors have seen him, but they don't know that there's a memory problem there. And so they don't go out to kind of redirect him or her back home, and realize later now law enforcement has to be called. The person is missing after 2 hours. And, then it's different now because you really need to share the information. So stigma does affect getting help. It does affect the level of stress that the caregiver, those who are caring for the individual with the diagnosis, because if that individual is carrying the complete load, it's a lot. We're also hearing about many caregivers who have died in the throes of caregiving. And that's very difficult to hear.
In other words,
Caregiving, yes.
has become a danger to people's health as well, has endangered their health.
Yes. There is a book entitled The 36-Hour Day, which describes the work of a caregiver from the time the person gets up and even before until they go to bed, and all the work and the duties that come along with caregiving.
So thank you. Maybe you could put that in the chat, and we will share all of the information in the chat that people have given us, links and research. There's so many more questions. This is the first of 3 briefings where we will look at the next briefing at the impact of Alzheimer's on women, both as patients and as caregivers. And the 3rd briefing will look at the issues of being isolated and the challenge to access care when you're in remote, rural, especially rural, small town, unincorporated communities. How does one address the issue of care when it comes to isolated communities? Yes.
Randy, I'd like to add one thing.
Please.
Economic value or economic cost of dementia care and caregiving is astronomical. There have been many reports out there by the Alzheimer's Association, by Us Against Alzheimer's, by many government groups as well. So the financial hit of dementia really is borne by individuals and families. So we have to recognize that. And who gets most of that hit is our people who identify as women.
Right. Thank you. I want to ask a question of each of our speakers on the call, a final last 30-second, 1 minute at most. We are all journalists. We are all connected to this topic in personal ways. You could see it in the questions. We want to know what you think the most effective reporting we can do to address stigma in our communities. What is your wish to see us do? Certainly connecting to you as sources is very valuable. What do you hope to see more coverage of in our media about stigma? And let's start with Dr. Abascal.
Yes, I think that there's 2 main things. The first one is raising awareness that Alzheimer's is a disease. It's not the person's fault. It's not normal part of getting old. It's a disease and it must be treated as such. And also a very important thing is linking people to care. There are services, and I don't only mean healthcare, I mean social service, legal services, obviously health services, getting those and linking that to care. We don't
Sure.
want communities to wait 10 years to get the help they can get right now.
Excellent. Dr. Aranda, what would you like to see more coverage of by us on the stigma issue?
I think one of the biggest things is, I'm going to go out on a limb here, is I'd like for stigma to also be viewed from the viewpoint of policies. What employment policies, public policies, economic policies in the state and in our country can be developed to buttress and support people living with memory loss and their family members. And I can tell you, more supports will little by little chip away at that stigma.
Yes, that's excellent. And Luna Crisanta, what would you like to see more coverage of on the stigma of Alzheimer's as it impacts LGBTQ, but just overall?
Yeah, I think beyond just the kind of educational component that folks have talked about, I think really humanizing the experience in your education so that folks can also begin to recognize perhaps signs in their loved ones, in their community, in themselves. I think that so often Alzheimer's and dementia is something that couldn't happen to me or wouldn't be happening to me. But in humanizing our stories, hopefully we can begin to see ourselves in them.
Thank you. These are excellent suggestions. Petra Niles, what would you like to see more coverage of, particularly in the ethnic media, on the stigma question?
I'd like to see more awareness from the perspective of brain health. We only get one, and so it's important that we reduce our risk in the ways that have been proven to be helpful, but also to be able to share local resources. Alzheimer's Los Angeles is a local resource that provides a variety of services. So we want to get the word out about that. So as was shared earlier, is that families will know where to go. So it's important for that to be shared. Thank you.
That's terrific. I want to thank each of you for your time. This has been a tremendously helpful first of 3 briefings, and I look forward to sharing the coverage with you that we generate and thinking more optimistically about the illness of Alzheimer's, that there are steps to be taken. I think your point, Dr. Aranda, that the more there is a sense of support and recognition through policy and through local community agencies, the more we do chip away at the stigma, which is often driven by a deep fear. So thank you so much for helping us normalize the conversation. I think it's helped all of us listening to you, and I wish we could go on, but the hour is now. We will end the conference with our thanks.